Hello everyone, welcome back to MedSound Bites. Today we will be talking about pharmacokinetics. So as the name suggests, kinetics, tick tick tick. So this is a relation between the drug and the time, right? So whatever the body is going to do to the drug is what is referred to as pharmacokinetics. It have four basic processes, that is absorption, distribution, metabolism and excretion. Very importantly, what we should be knowing in absorption is bioavailability. It is denoted with the letter F, and it is the percentage of given dose which will reach the systemic circulation in an unchanged form. And it is always calculated with the area under the curve, right? It is always calculated with the area under the curve, and the formula is area under the curve for any root over area under the curve for IV, and we multiply it by 100. Now just think and tell me, for what root the bioavailability is going to be 100%. That is, the drug is going to reach systemic circulation in an unchanged form, wholly, fully, and that is going to be, yes, you guys are correct, that's intravenous route. When we are going to administer a drug via intravenous route, the bioavailability is going to be 100%. It is going to be what? It is going to be 100%. The next is going to be the distribution. If we talk of distribution, guys, here we have to talk about the volume distribution. This is and the plasma protein binding abilities of a drug, right? So volume of distribution, which is denoted by VD, is depicted with the formula D by C, which is the dose of the drug over the initial plasma concentration. Over the initial plasma concentration. This is what is referred to as the volume of distribution. Now this is if we understand something like how do we say, like the more the amount of drug is entering the tissue, right, the more it has the volume of distribution, right? So what I mean is that if a drug has high volume of distribution, it simply means that that drug is present more in the tissues and not in the systemic circulation. That drug is present more in the tissues, okay? So just think, when we are performing dialysis, those drugs which have got a high VD, how are they going to be affected? Will they be purified? No, right? Because dialysis is all about the systemic circulation, and when we are saying that a drug is having a high volume of distribution, it means it is present in the tissues. So dialysis will not be effective against drugs which have got a high volume of distribution. For example, benzodiazepines or beta blockers, digoxins, opioids, calcium channel blockers, amphetamines. These are the drugs which are very high, which have got a high VD, and thus dialysis will not be affected in them. You can remember it with a mnemonic called BAD DOG, where B stands for benzodiazepines, beta blockers, A stands for amphetamine in the BAD, and D will be digoxin. Then we have DOC, so here D does not depict anything, and O stands for opioids and organophosphates, and C stands for the calcium channel blockers, right? So this is the volume of distribution, and it is denoted by dose over the initial plasma concentration, right? Then we have a plasma protein binding. Now basically we all know that the free form of the drug is the form which is going to be active. So if a drug is bounded more to a plasma protein, right, of course it is going to be distributed less, right? So more is the plasma protein binding, lesser will be the distribution of the drug, right? And acidic drugs are the ones which go and bind to albumin. Acidic drugs like barbiturates, benzodiazepines, phenytoins, penicillins, NSAIDs, warfarin, tetracycline. And basic drugs will be going and binding to alpha-1 acid glycoprotein like verapamil, beta blockers, tricyclic antidepressants, opioids, and lidocaines, right? This was our distribution part. There is a thing here which is called as a loading dose. Loading dose is basically required to attain a particular plasma concentration, right? So as to attain a particular plasma concentration, we require a loading dose. And loading dose is what? It is going to depend on what? It is going to depend on the volume of distribution only, right? So loading dose is thus apparent volume of distribution multiplied whatever is the target plasma concentration. Whatever is the target plasma concentration, that is referred to as the loading dose. And maintenance, there is one more thing that is called the maintenance dose. Maintenance dose is the amount of drug that is required to maintain a target plasma. Loading dose was to attain a particular plasma concentration, and maintenance dose is to maintain the target plasma concentration, right? And this is clearance multiplied by the target plasma concentration. So it is clearance that is multiplied by the target plasma concentration. Okay guys, further moving on to metabolism. Metabolism is, saying it very simply, it's something that will make a drug water soluble. Okay, now we have two reactions, phases of reactions here, phase 1 and phase 2 reactions. Phase 1 reaction is all about inactivating a drug, inactivation of the drug. But there is exception. Prodrugs are going to be activated when they are metabolized. Prodrugs like ACE inhibitors and ARBs, but in ACE inhibitors except for captopril and lisinopril, and in ARBs except for olmesartan and candesartan, rest all of them are prodrugs. Proton pump inhibitors, levodopa, methyldopa, clopidogrel, these are all prodrugs, right, which are going to be activated when undergoing phase 1 reactions, right? These are the most common reaction that we see in phase 1 is oxidation, but there is also reduction, hydrolysis, cyclization, deamination, but the most common is oxidation only. Then we go to phase 2 reactions. Phase 2 reactions are where the drug is made water soluble. So the drug is made water soluble in phase 2 reaction, and the most common reaction that we see in phase 2 is glucuronidation. But there's also acetylation, methylation, sulfation, and glutathionation. Now there's a point to remember that geriatric patients, they tend to have more of phase 2 metabolism in their body. So if there is a old patient who is having a decreased acetylation, right, so that is of course a problem, because the drug is not going to be metabolized within their body, and they can have toxicity, right? So this is something to keep in mind. If on question you see something like this, so just keep it in mind. Then we go on to that there is this cytochrome 3A4, which is responsible for the metabolism of most of the drugs, right? So for most of the drugs are metabolized by the cytochrome 3A4, but there is also cytochrome 2D6 after cytochrome 3A4, which is also responsible for metabolizing the central nervous system and cardiovascular drugs. Then there is cytochrome 2C9, which is for warfarin, and then there's 2C19, which for clopidogrel, and there are many, but majorly what we need to know is of cytochrome 3A4, responsible for majority, and cytochrome 2D6, which is for central nervous system and cardiovascular drugs. Right, now there are certain drugs which are inducers of these microsomal enzymes like cytochrome, right? And then there are also present some enzyme inhibitors. So if we will be talking about enzyme inducers for cytochrome P450, the enzyme inducers are, here we have the mnemonic brags about PC. It's just a silly mnemonic, but brags about PC, the personal computer. So those times are gone though, but still. So we have brags about PC. So B stands for benzpyrene, R stands for rifampicin, A stands for alcohol, G stands for griseofulvine, S stands for the St. John's wort, so there is what brags, and then we have about, we don't have anything from about, and then P and C. So P stands for phenytoin and phenobarbital, and C stands for cigarette smoking and carbamazepine. So these are enzyme inducers, and they're very essential to remember, guys. Don't please forget them, just remember them, keep them in mind. For example, these are clinically relevant things. For example, there's a female who is on oral contraceptives, and then she's taking rifampicin along with it, right? So the the rifampicin, as we now just now studied, that these are enzyme inducers, so the drug will be metabolized more in such patients. So this is something that can cause a OCP failure in her, right? So these are the clinical relevant things, and this you should know, these enzyme inducers and inhibitors. Enzyme inhibitors are, the mnemonic here is a quick wedge dish. Okay, so Q is quinidine, U, we don't have anything, quick in Q, U, nothing, and then we have go to I stands for isoniazid, and C stands for cimetidine, chloramphenicol, ciprofloxacin, and K is the ketoconazole. Then V in wedge stands for valproate, E stands for erythromycin, G stands for the grape juice, and finally the quick wedge dish. So here the D is disulfiram and DEC. So it is what? It is disulfiram and DEC. Okay. This was about the metabolism, and then we talked about the enzyme inducers and enzyme inhibitors. Now we go on to the last part of it, that is excretion. Now excretion is the removal of the drug from the body, of course, and it's a function of the glomerulus. We have got filtration, tubular reabsorption, and tubular secretion. Now when we talk of filtration, it will depend on the plasma protein bounded drugs, right? Because of course we know that protein is something that's not going to be filtered, right? So protein bound drugs, they will not be filtered, and the renal blood flow is not going to promote that. But so basically the filtration is depending upon the plasma bound drugs, and we should know that the plasma protein bound drugs will not be filtered, and thus will be difficult to eliminate from the body. If we talk of tubular reabsorption, more the lipid solubility of the drug, more the reabsorption, and lesser will be the excretion, Now to eliminate a drug, we can change the pH of a urine. For example, if there is a acidic drug toxicity, then we can make the urine alkaline, and if it is a basic drug poisoning, that we can make the urine acidic, right? So we can thus this is a way of treating toxicity. So urine's pH can be changed to make the drug ionized. For example, we can administer either sodium bicarbonate or ammonium chloride in the toxicities. And finally, we have got tubular secretion, which does not depend upon the lipid solubility or the protein bound drugs, plasma protein bound drugs. It's independent, it is not depending upon anything. Now we have a thing here which is called a rate of elimination. Rate of elimination is the amount of drug that is eliminated per time, right? Per time taken. So ROE is amount of drug eliminated over the time that is taken. And clearance is the rate of elimination over the plasma concentration, right? So whatever is the rate of elimination over the plasma concentration. And we've already talked that there is a thing called as maintenance dose, right, which is going to be the plasma concentration, and plasma concentration multiplied by the clearance, which is then also multiplied by whatever is the time that is being taken. But above we did that it is the clearance multiplied by the target plasma concentration, right? Target plasma concentration and clearance. That is how we know about the maintenance dose. Okay, now guys, this is important. The order of pharmacokinetics, 0 order and first order. This is very important. Most of the drugs are the ones which are going to follow first order kinetics, so the questions is going to be asked more from the 0 order kinetics, of course. Now these are, let's just say, if we talk of 0 order kinetics is when the amount of drug that is being eliminated is constant. For example, there's a 500 milligram of drug is removed at a rate of 50 milligrams per hour. So it is that 50 milligram per hour is going to be removed. For example, from 500 it will go to 450, then 400, then 350, like this, right? So the amount is constant, right? The amount is constant. Here we will say that the clearance is inversely proportional to the plasma concentration. So in zero order kinetics, the clearance is inversely proportional to the plasma concentration. If the plasma concentration of the drug is more, the clearance is going to be less. The amount of drug that's going to be eliminated is going to be constant. If we talk of the rate of elimination, we know, since it's the same amount of drug that is being eliminated, it is going to be constant. It is going to be what? It is going to be constant. This is what we should be knowing of zero order kinetics. And the drugs which act via the zero order kinetic is warfarin, alcohol, aspirin, then there is theophylline and phenytoin. These are some drugs which you should remember. Alcohol follows pure zero order kinetics, so it's warfarin, alcohol, aspirin, theophylline and phenytoin. Okay, and patients are more prone to have toxicity with zero order drugs. Then we move on to first order kinetics. First order is where we are going to say that it is a fraction eliminated per unit time is constant. So the fraction of drug elimination per unit time is constant. For example, 500 milligram of a drug which is removed at 50% per hour, right? So it is, for example, 500, and then it will be 250, and then it will be 125, and then it will be 62.5. So it's the 50% per hour that is being eliminated, right? And it takes about 4 to 5 half-lives to remove most of the drug from the body and to achieve a steady state concentration, right? So it's very important for us to know that, like, it requires 4 to 5 half-lives to remove most of the drug from the body and reach a steady state concentration. Now here in first order kinetics, the rate of elimination is directly proportional to whatever is the drug concentration. If the drug concentration is more, the rate of elimination will also be more, because here we're talking of a fraction that of drug that is being eliminated, right? So if the drug is more, the rate of elimination is also more, because rate of elimination is the amount of drug that is eliminated over the time that is taken, right? And in zero order kinetics, this amount was same, so rate of elimination was constant. Now if we talk of clearance here is going to be constant. In first order kinetics, the clearance is constant, right? The clearance is going to be constant here. And most of the drugs are known to follow first order kinetics only. Now when you see the graph, right, for concentration time graph for first order and zero order kinetics, and first order kinetics, very important to understand the initial drop that you see in the graph is because of the distribution of the drug and not because of the elimination, right? It is because of the drug being distributed in the body that you see the initial drop, and finally moving down you see more drop. That is because of elimination. So clearance and dose, if we should understand, the clearance and whatever is the dose of the drug determines the magnitude of the steady state, right? So for example, we are saying that the drug is requiring 4 to 5 generally we require 4 to 5 half-lives to reach a steady state concentration. Now the steady state what is going to be the magnitude of that steady state concentration, whether a drug attains steady state concentration at 80 milligrams or 50 milligrams, this is something that is dependent upon the clearance as well as the dose. But to determine the time it will be required to reach the steady state concentration is T half, right? We haven't talked about it. T half is the time that is required to reduce the amount of drug in the body by half, right? So it is the time that is required to reduce the amount of drug in our body by half, and this T half determines the time it will require to reach a steady state concentration, Okay guys, that's all for today. If you find this video helpful, please do like, share and subscribe to the channel. Good luck everyone, and thank you very much.